Good evening, everybody. Like a pleasure and privilege for me to welcome you to this program. And as you know, today we are going to be discussing hormone receptor positive metastatic breast cancer. And if you leave aside the past 5 years, we all know that there was no progress in this field other than tamoxifen and the aromatase inhibitors. We had no drugs till almost 2 decades. And then since the past 5 years and since the arrival of the CDK4/6 inhibitors, there's been phenomenal progress in the field. And we are now tailoring treatment of our hormone receptor positive MBCs to the molecular profile which they have. And we have first-line endocrine treatments, second-line endocrine treatments, third-line endocrine treatment, maybe fourth-line endocrine treatments also before we think of chemotherapy in these patients. And this is an important subgroup of patients because, as you're aware, that a significant number of patients in our country are hormone receptor positive, whether they be premenopausal or they be postmenopausal. And the concept of estrogen receptor resistance and the genes which drive this resistance is now emerging. There has been a massive increase in the knowledge as well as the availability of molecules which were known as the estrogen receptor modulators or the SERDs. We had only, or at the moment, we have only the intramuscular molecule fulvestrant, but now several oral molecules are on the anvil, sitting on the threshold. Some have been launched and some are about to be launched. So the field is really opening up to a lot of excitement. Today, what we are going to do, the format for the day is going to be that we are going to have 3 talks. The first talk is going to be by Dr. Trupti Pai. Then we'll have our international speaker talk to us about the advances in this field. Then we have a talk by Dr. M.V. Chandrakant, and who will also drive the question answer session, followed by a panel discussion, which will be moderated by Dr. Shyam Agarwal. So not to waste any more time, we will launch into the first talk of our program, which is titled Molecular Monitoring, ctDNA, and ESR Mutations. And this talk is to be given by Dr. Trupti Pai. It's my pleasure and privilege to introduce Dr. Trupti Pai to you. She is professor of pathology at the Tata Memorial Cancer Center, and she's done some sentinel work in the field. And she's published very extensively. She's a speaker at most of our conferences. I'm going to hand over the podium or the virtual podium to Dr. Trupti Pai to take the program forward. Over to you, Dr. Trupti. Thank you.
Thank you, Dr. Hemant, for a kind introduction. So can I share my slides, please?
Yes, ma'am.
Is it visible?
No, ma'am.
No? It's not?
Yeah.
Yes, ma'am, it is visible.
Now we can see. Please go ahead.
Oh, no, because she said 1 minute. I will share again. Please check now.
Yes.
Okay, fine. So next 15 minutes, I will be talking on the molecular monitoring that is liquid biopsy, ctDNA, and ESR1 mutations. But before that, I thought I will give a broad overview just for the flow of the talk about the causes of resistance in hormone-positive breast cancers, what are ESR1 mutation and how it leads to tumorigenesis. 2 main trials which will be covered on in details. I will just give a broad overview. Then we will see what are the nuances of liquid biopsy pertaining to ESR1 testing, certain pre-analytical and analytical considerations, what are the guideline recommendations for reporting liquid biopsies, and what are the conclusions. So we know that over 2/3 of the patients of breast breast cancer are hormone receptor positive, approximately 70%. And most of the times, the first line response is the key as outcome worsens in later lines. And what is the cause? What is the cause for this? Is endocrine resistance. So endocrine resistance is most of the times the cause for the declining efficacy with the later lines of treatment. So what are the broadly, if you see the broad classes of endocrine resistance, is we are dealing with the ER signaling pathway. So any alteration in the ER pathway like mutations, amplifications, then if there are any escape, that is the bypass signaling pathways like activation of PI3K, AKT, mTOR pathways, or there is a cell cycle dysregulation or any epigenetic reprogramming, that is changes in the gene expression of these genes. So of this, the most common and the well-documented cause is of the ESR1 mutations. So what happens normally in estrogen receptor signaling is that estrogen will bind to the estrogen receptor. Then there is receptor dimerization, that is both receptors come together. Now this complex then goes to the nucleus and then it binds to the estrogen response elements gene sequences, and this leads to increased transcription of the estrogen responsive gene. Now this further leads to increased cellular proliferation, metastasis, angiogenesis, and leading to this is the normal pathway. So when this is dysregulated in hormone positive, it leads to tumorigenesis. Now when we use aromatase inhibitors, there is decrease in the estrogen. So there is decrease in the estrogen dependent signaling pathway. But what happens is there can be because of the selective pressure, there can be an ESR1 mutation, which leads to estrogen independent signaling, leading to increased transcription. Now, if you see, the treatment with AI drives the development of ESR1. So if you see, if approximately 5% of patients have detectable ESR1 after adjuvant AI, after the start, after approximately 1 year, this count is approximately 40%. So what does this say? That incomplete inhibition of estrogen synthesis by AI, this allows the residual, so there is a tumor advantage, and then there is this adaptive upregulation of alternative pathway and all these alterations. So these two main trials, now this PADA-1 trial and later Serena-6. So what was the main thing is, so these are all on the metastatic breast cancer, which are hormone receptor positive and AI sensitive. The hypothesis was to detect liquid biopsy based ESR1 emerging mutations even before there is a clinical disease progression. And when they stratified this depending on the ESR1 mutation, they showed that there is a significant increase in the median progression-free survival. So this was the first evidence to support that ESR1 monitoring using a liquid biopsy during the first line of treatment. Subsequently in Serena-6, so if you look at the design, so this was around patients on the first line aromatase inhibitors with CDK5/6 inhibitors for more than 6 months. After that, ESR1 testing was done every 2 to 3 months. And of this, approximately 17%, that is 548 patients, were detected with ESR1 mutations. Now, after that, there was a randomization. So if you see the positivity of the test, approximately 51% were tested positive at the first test. So it was at the baseline, and later, after every 2 to 3 months, it was tested. So this was the first phase 3 trial, clinical trial, which supported again that the serial monitoring for ESR1 mutations in liquid biopsy can help us detect the clinical outcome. That is switching for this hormonal treatment. Now both this, so if you see the PADA-1 trial, so the technique that was used was a droplet digital PCR, which focused on the hotspot alteration, and the frequency, that the lowest possible frequency was approximately 0.1%. Whereas in Serena-6 Garden 360, that is the NGS based technique was used. And this is also very sensitive, and it is a broad based coverage of the ESR1 gene. So these two trials showed us that it is very important and essential to detect the ESR1 alteration. Why? Because it is an early predictor of acquired AI resistance. Also, the ctDNA mediated serial ESR testing can identify patients with acquired resistance even before the clinical progression. So it is very important to do this testing, and that is why we should know what are the testing nuances. Another thing, if you see as against the other alterations, in early breast cancer or at baseline, the frequency of ESR1 mutation is almost 0%, whereas it increases at subsequently at different progression or recurrence. But if you test at one time point and it is negative, you cannot just stop at that. You have to do a testing at each progression. So that is the point to be made here, that at baseline it is negative, it develops under selection pressure, but at every progression, if prior test is negative, you have to proceed with the testing for ESR1 alterations. Now with this, which are the different clinically actionable ESR1 mutations? So there are many mutations, but the hotspot mutations are mostly located in the ligand binding domain. So does that mean outside this domain it doesn't happen? No, there are certain mutations which are located even outside the hotspot region. Now that is where it is important to know that which panel and which platform you are testing and by which methodology. So prevalence of ESR1 mutation is higher in liquid as compared to tissue. So there have been studies and then publications which showed that liquid biopsy is better for ESR1 mutations, because we should know that it is after the treatment under a selection pressure, as well as you have clonal and subclonal alteration, which will be at different progression and different lines of setting. So better than tissue, it is important to address liquid biopsy. So most of the time in lung cancers also we see whether liquid biopsy, tissue biopsy, and both goes complementary in each other. This test is especially, it is important that we should know that liquid biopsy is better in capturing the spatial heterogeneity and the subclonal alterations. So with this, we will see what is the liquid biopsy. So basically, what are you doing with liquid biopsy is you are taking blood, separating plasma, and then you are trying to identify tumor-related biomarkers from this plasma. But the point to be kept in mind is that this plasma will have cell-free as well as the circulating tumor DNA. So not everything that is extracted DNA from this plasma will be a tumor DNA. You can have this DNA from healthy tissue as well as from the tumor tissue. Now the ctDNA from the percentage of cfDNA is very less, and that is why all the technical nuances we should be very thoroughly utilizing when we are dealing with liquid biopsy, because it is a very tiny proportion of cfDNA. So what are the liquid biopsy pros and cons? So if we look at the pros, there are many, right? It is a minimally invasive. You can do serial sampling. Patients are also happy. There is no, like, it is not an invasive technique. You will get rapid results because there is no steps of tissue processing like usually, which delays the things. It takes care of the heterogeneity, as well as you can detect actionable mutation at a very low VAF also. But what are the cons is that the limited sensitivity. As we saw that the ctDNA proportion is very less as in cfDNA. First of all, cfDNA is less. In that, it is also less than 0.1% of cfDNA, that is a ctDNA. So to capture that kind of low level of alterations, you should have a very high depth of the sequencing that you are doing. That leads to a costly technology and a very expensive technique. Also, if you don't pay attention to minute details in the pre-analyticals, there will be contamination with the wild type DNA, and your already less quantity of ctDNA will further get diluted and you will get a negative. So you should keep in mind that majority of the samples have a very low circulating tumor DNA, while only minority will have a high ctDNA. Plus, there are different concerns, like different laboratories use different platforms, different depth, and sometimes because of the cfDNA, the alterations may be confounded by chip. So because of all these points, we have to be very cautious when we are dealing with the liquid biopsy. Now, which are the certain small steps that we can pay attention to have a successful liquid biopsy test is that how you are withdrawing the blood, how much quantity you are taking this blood, how early you are separating blood plasma from the blood, then which tubes are you using? So if you are using a stabilizer tube, then it will remain stable for up to 48 hours. But if you are taking EDTA tubes, then you have to separate it within 2 hours. So after you collect the blood, it should reach the sample, it should reach the lab within 2 hours. Then if you shake the tube very vigorously, it will again lead to lysis of WBCs. So you have to be very gentle with all these processes. how you are storing. You cannot freeze the blood sample. You can maybe separate plasma and make different aliquots of it. How your centrifugation steps. So there are 2 centrifugation steps and it has to be done under a lower temperature. So all these points, so stringent pre-analytics is the key for the liquid biopsy. Once you have extracted the cfDNA, you have to do a quality check, and you have to do how much of this DNA is a cell-free DNA. So you will use a tape station or anything, and that will give you how much of this extracted DNA is cell-free DNA. So most of the time, if the cell-free DNA, you get a graph saying what is the fragment length of the DNA that you have extracted. And with this, you can exclude the wild type, or you will get an idea of how much is the cfDNA of the extracted DNA. So all these steps you have to pay attention to when you are dealing with a liquid biopsy. So this was regarding that extraction and initial steps. So what happens when you extract the ctDNA? What assays are you performing? So as I say, one trial made use of droplet digital PCR, whereas other made use of NGS. So if we see ddPCR is also a very sensitive technique, you can go to a very low level of depth and identify subclonal alterations, but it will again be a very limited throughput. So we saw there are different ESR1 alteration outside the ligand binding also. But if you just want to focus on the hotspot, like the PADA1 trial, it focused on the 4 main hotspot, which comprises more than 90% of the ESR1. So if you have that thing in mind, then maybe droplet digital PCR is a very sensitive. But with that, you will not get access to other genes or any other alterations of ESR1. No doubt it is highly sensitive, but it all depends on what you want to test. Whereas if you see NGS, if you have very high depth and a very sensitive platform, along with ESR1, the entire exonic region also, you can have multiple genes which are addressed simultaneously. You can detect co-mutations. You can also detect copy number variations or any fusions. So you get in one go multiple other alterations. So both are highly sensitive. Again, depends if you just want to chase ESR1 or you want to take other alterations also into consideration. So again, like we have different ddPCR, qPCR based tests. So this is a chart which shows, like, if for example, these are the mean alterations, you can see some of the tests are also missing this. So whenever we are testing for ESR1, the point here is that we should be aware. It is not just that it is positive or negative. Any of the physicians, clinicians should be aware of what panel you are using and what is the type of chemistry of that platform. So it will be very good for analyzing later. So not all ddPCR, qPCR can detect all clinically actionable variants. Similar with NGS, you will have different assays which are available in the market, again with a different sensitivity. So some might have 0.1% sensitivity, some might have 0.5, 0.05. So it will be very varied. But as I said, it is in one go, you will get results of all other alterations, co-mutations. Also with a very low VAF, you can detect the alterations. So then comes the question, which is the right time to test for ESR1 mutation and how long should it be monitored for? So in the secondary analysis, we saw that the detection of ESR1 mutation was lower before 6 months and after 30 months. So for pragmatic or for a proper approach, maybe monitoring of ESR1 in HR positive breast cancer should begin post 6 months of the treatment and should be repeated every 2 to 3 months till 30 months. And this will maximize the probability for detecting ESR1 mutations. So this was about the ESR1 mutations, like which mutations when to detect. Now, in general, if you see, there are CAP recommendations, because for this alteration, liquid biopsy is very, very useful and very important. So it is better to stick to the guideline recommendations for testing and for reporting. So whenever there are ctDNA mediated recommendations, so you should clearly know what is the medical indications. Now, there is no point as such in doing liquid biopsy for a baseline breast cancer as of now. So like this, we should know what is the medical indication for the test. What are the clinical assay performance? What is the limit of detection? What is the analytical sensitivity? Potential source of interpretation error. Like I said, if you are getting a quantification of cfDNA and of the total extracted DNA or cfDNA is just 5%. There is very less probability that it has even the circulating tumor DNA in it. So there is no point in doing the test. So all these potential sources of assay interference should be made note of. And then whenever sometimes you get very low VAF and you are confused whether it is because of the sequencing error or it is pertaining to actual tumor, you can use some orthogonal method of for confirmation. For example, if you are getting something at a very low VAF on NGS, maybe if you have a similar ddPCR assay, you can do that. So that is the meaning of a orthogonal testing. But if you are getting a very low VAF and NGS and then you are testing with qPCR, RQPCR, then maybe the sensitivity of qPCR is not that great. So to detect low VAF, you can maybe use a ddPCR as a orthogonal testing. So again, the recommendations for clinical ctDNA reporting is that on the report also you should mention what are the pre-analytical variables, when was the blood collected, in which tubes, how early was the plasma separated, describe all the analytical variables reporting, which is the tier mutations, analytical sensitivity of the alterations, and all the information regarding the laboratory policy for orthogonal. So if uniformity is kept in a reporting of liquid biopsy, it will be very good for reproducibility, or maybe if reports are going from one lab to other, it is easy to interpret also. So there are these guidelines which are there for the liquid biopsy reporting. So with this, the key takeaway is that ESR1 mutation predicts AI resistance in patients with hormone receptor positive, HER2 negative metastatic breast cancer. ctDNA mediated serial ESR1 testing has potential to predict relapse before clinical progression, and the ideal interval for testing is between 6 to 38 months. ctDNA mediated serial ESR1 testing can be integrated into laboratory workflow using available approaches and the resources. With this, I would like to end my talk. We'll be happy to take any questions. Thank you.
So thank you very much, Dr. Trupti. That was a wonderful talk covering most of the molecular aspects and the advances in the molecular aspects of this topic. We will do the, most of the questions after our international speaker talk, and we will also cover some of the questions during the panel discussion. I see that there are close to 50 participants for this webinar, and I would strongly urge you to post your questions on the chat box, and we will try to address all the questions after our international speaker talk. So, ladies and gentlemen, it is my unique pleasure and privilege to welcome our today's international speaker, Professor Giampaolo Bianchini. Professor Giampaolo is Associate Professor at the Vitae Salute St. Raphael University and is the Head of Breast Oncology at the Department of Medical Oncology at the IRCCS St. Raphael Hospital. To give you a little bit about his background, after graduating, doing his undergraduation in 2000 from the University of Milan, he specialized in medical oncology again at the University of Milan. During his training, he was a visiting scientist at several prestigious international universities like the National Cancer Institute in Bethesda, the MD Anderson Cancer Center, and the Yale Cancer Center. In addition to his clinical responsibilities, Professor Giampaolo is also head of clinical translational and immunotherapy research groups at the Department of Medical Oncology, and he has numerous research projects aimed at patients with breast cancer. Needless to say that Professor Bianchini has authored numerous publications in various international journals, including Nature and Lancet and Annals of Oncology and many others. So Professor Bianchini today is going to take this topic forward and talk to us about optimizing treatment strategies with precision therapy decisions in hormone receptor positive metastatic breast cancer. So I'm going to hand over the proceedings to Professor Bianchini now. Over to you, sir.
Thank you very much. Thank you for the invitation. Thank you for the opportunity to discuss with you this very, very interesting topic. This is my declaration of interest, probably the most important thing that I'm a steering committee member of Serena 6. So when I will present the data, just take in account this element because, of course, can affect my judgment. You know, the old ESMO guideline in ER-positive to negative metastatic breast cancer essentially say first line, if available, is endocrine therapy CDK for all comers. But that's really one size fits all. And what about the biological heterogeneity? Because in ER-positive to negative breast cancer, as was well presented before, we have several recognized valid targets: estrogen receptor, PI3K, PTEN, AKT, mTOR, the surface receptor, TROP2, HER2, and germline alteration, like BRCA1, BRCA2, PAB2, somatic BRCA mutation, CDK4/6 inhibitor. And so all these matter in first line. So far, what is matter is in endocrine-resistant tumors, primary or secondary. You know that if the patient has a PI3K mutation, just a PI3K mutation, you can potentially consider as an alternative to CDK and fulvestrant, using fulvestrant, palbociclib, a CDK4/6 inhibitor, and inavolisib, according to the results of the INAVO 120 trial. INAVO 120 trial, endocrine-resistant population, randomized to receive palbo-fulvestrant compared to inavolisib palbo-fulvestrant. This is the results in terms of response rate. I would like you to notice 62.7% overall response rate in an endocrine-resistant tumor is really an amazing result. And also look at the duration. It's not just much more response, but also the duration of the response is much longer. So you will not probably surprised that this treatment reduced the risk of progression of 58%, and the median PFS inclusive of almost 10 months, also almost 10 months of increase of median PFS. And probably the most important one, these are data presented from the day at ASCO, the statistically and clinical meaningful improvement of overall survival with an hazard ratio of 0.67. So what about the implication of this heterogeneity in molecular biology for the post-CDK landscape? And that's one size fits all. We will address in more detail later, but what is for sure is that we need to select a target-driven treatment in the post-CDK area. And indeed, the recent revised NGS recommendation from ESMO say that we should perform an NGS testing for this drug, not a general NGS testing, at the appearance of resistance to endocrine therapy. So this is the first type of application of ctDNA. So potentially, the previous presentation was really, really good to introduce the concept of ctDNA. You can use ctDNA to detect molecular alteration and to match this molecular alteration with targeted therapy. That is a recognized and therapeutically relevant application of ctDNA. Potentially, there is another application of ctDNA to use this as early monitoring of treatment response. What does it mean? It's very simple. The dogma in oncology is we change a treatment in metastatic setting when there is a progression, is a clinical progression or imaging. For imaging, we have, like in trial, the RECIST criteria. So can we challenge the dogma? So can we think that it's better to change the treatment without a clinical progression? So first of all, I would like to mention that liquid biopsy provides information in this setting. So the standard is you do an imaging, you repeat the imaging in a longitudinal monitor, you see a partial response, and then you have a progression. But you can potentially use liquid biopsy to really follow the decrease of the variance allele frequency of the mutation and the following increase. This nice publication of Annals envision the potential creation of liquid biopsy RECIST criteria. That means using liquid biopsy to really indicate a potential progression. That's come to the concept of molecular progression as opposite of imaging and clinical progression. So now I will start to discuss a little bit more in deep dive what can change in the endocrine sensitive, endocrine naive population. So the SERENA-6 trial essentially merge these two aspects. On one way, monitoring treatment and identify molecular progression and decide to change the treatment at molecular progression, not at clinical progression. The second is to match the appearance of a druggable molecular alteration, ESR1, with a very potent treatment that is able to overcome this resistance. Just a little bit to the concept. So the SERENA-6 doesn't enroll all first line, but endocrine sensitive. So in endocrine sensitive, you are in estrogen deprivation environment. And this is the situation. You have aromatase inhibitor plus or minus ovarian suppression. So in this context, the tumor can overcome the resistance, generating mutation that help the receptor to bind to the DNA without the need of a ligand. So I don't have estrogen, but I don't need it because the mutation allows me to bind to the DNA. Be careful. This is the reason why you have the appearance of this alteration only in estrogen deprivation environment, not with tamoxifen, not with fulvestrant. And this is an acquired resistant mechanism. So it's acquired because, again, emerge under the evolutionary pressure of a treatment. But I would like you to mention a very important point, was also mentioned before. When you have this molecular alteration, you have a reshape of the cell biology towards a more aggressive behavior. What does it mean? That is not just that the estrogen receptor bind to the DNA without the ligand, bind in different sites and bind in a different way. So transform the biology of the cell, making them more aggressive, making them more basal-like oriented. And this is the reason why when you look at ESR1 mutation, the prognosis is worse. And this is the reason why when you have ESR1 mutation, you have higher homing in the liver, so more liver metastasis. And we know that these metastases frequently lead, unfortunately, our patient to die. So how we target this alteration? We cannot use aromatase inhibitor. We need a degrader. And degrader now are served in the future PROTAC and other drug we will develop. So the conventional timing of targeting ESR1 mutation is this one. Imagine now I have the baseline endocrine sensitive patient, no alteration within the cell of ESR1 because the tumor don't need it. And you start a treatment with aromatase inhibitor plus or minus CDK4/6 inhibitor. Then you continue the drug. At a certain point, emerge a clone that is resistant, acquired alteration. Before, if you look in the blood, the ctDNA is negative, but then become positive. This moment in which you have a shift from ctDNA negative to positive is called molecular progression. You see partial response. So you still have a overall benefit, but you have a molecular progression. That at a certain point, you still have ESR1 mutation in the blood, but you also have a clinical progression. So the TCA assessment say you have a progression. So that is the standard moment in which we give a Lachestra. The SERENA-6 essentially mirroring the PADA-1 say, no, you should change the treatment at the time there is a molecular progression using fulvestrant, PADA-1, or camizestrant, SERENA-6. Just to remind the PADA-1 is a proof of concept trial. And these are the main results of the PADA-1. So you see a significant improvement in PFS. PADA-1 have some caveat. Just to remind, it's very nice trial, very nice proof of concept, but the two major caveats are this one. It's an open label study, and the main endpoint is the investigator assessed PFS. So it's not fair because the oncology know that there was a molecular progression, and some patients stay on the drug, and some other change the drug. So of course they was influenced to consider less progression when they change the drug, fulvestrant, and giving more progression when they look at the imaging in the standard arm, because they know that there was already molecular progression. The second one, they use a suboptimal SERD, fulvestrant. SERENA-6 overcome these two limitations. So it's a trial that is a double-blind trial, very important, double-blind. So no one, not the doctor, not the patient, know what the patient was receiving, and use the right drug. Use camizestrant, that is a very potent SERD. The design of the trial was already described. There was a surveillance phase, or the patient could, this is very important, very different from PADA. Patient could enter in the trial at any time. So at the beginning, we enrolled patient in SERENA-6 that was already on CDK for 3 years, 4 years, 5 years. So that is totally different from PADA that every patient start from the beginning. And randomize 315 patients to the two treatment arms. This is the randomization, camizestrant 75 milligram, and continuing the same CDK, or continuing the same CDK plus aromatase inhibitor. These are the population enrolled. Essentially, a fair proportion of patients was entering the trial with positivity at the first assessment or in the subsequent testing. So negative, then retest, then retest, then retest, and they enter when they become positive. The majority, 62%, stay before on CDK for more than 18 months, but 38 less than 18 months. And 76% has received Pibol, so the majority, but 25%, so not a small subgroup, receive ribo or abemaciclib. These are the main results. So adjusted reduction of progression, a proportional risk of progression of 56%. So to me, very important results. And I would like to do with you a deep dive of this curve, because sometimes we look at Kaplan-Meier, but we don't really look carefully to the Kaplan-Meier. So first, consider one aspect. The conventional way to use SERD is like a Lachestan, so at clinical progression. I can tell you that in Italy, we have data, real-world data, that suggests that 40 to 50% of the doctors do not want to use a monoendocrine therapy or an endocrine therapy, even with capivasertib. They prefer to use chemo at progression because the progression is bad. That's very different with the SERENA-6 approach, because the SERENA-6, because you enter patients that don't have a clinical progression, of course, you can offer all the patients the option of receiving the SERD. That's a very big, important difference. The second one, when you look at the data for the Emerald trial, you see here, in the first 3 months, you have 35 to 40% of patients who experience early progression. So a progression before the first TC evaluation. In the EMBER-3 trial with imlunestrant, is the same. You have 30% early progression at the first TC evaluation. And in the PADA-1, the patient who entered in the study and was in the standard arm, so the aromatase inhibitor plus CDK, when they have a progression, was offered to receive fulvestrant plus CDK. These are the results. 30% early progression, median PFS 3.5 months, so very limited effect. Look at the Kaplan-Meier in the SERENA-6. You have an early separation that happened in the first 3 months. So the benefit come immediately. And this is actually half of the progression. So that is a totally different situation compared to what we observe when you target the bulk of the ESR1 mutation. And is also mirroring, even more important, by the quality of life. So you see the quality of life. So the trials show an improvement in time to significant deterioration happen in the first 3 months, essentially. You see almost all the benefit immediately. Why? We will understand at ESMO. You will see more data to understand this element. So another reason why the SERENA-6 approach was designed is to say, okay, if I have a molecular progression, can I, using a SERM, revert the disease to endocrine sensitive? So eliminate this clone and continuing for a long time to give the drug. That is one concept behind. In SERENA-2 trial, as you know, is a positive trial demonstrated that camizestrant is better than fulvestrant in metastatic breast cancer. But look at the translational study. This is ctDNA for ESR1 mutation. Look on the left. With camizestrant, in many patients, you have a clearance of ESR1 mutation in the blood. With fulvestrant, you almost never have a clearance. Very few patients have a clearance. This demonstrates that camizestrant is probably really able to eliminate some clone. And these are bulky, non-molecular progression. So this is merging with this tail effect. Look at the right side of the Kaplan-Meier. 2 years, a long time. You had 29.7% patient free of progression with camizestrant and only 5.4% free of progression with the standard treatment. So it really seems that what is expected, the capability to reverse to sensitivity is maintained. We don't have any clinical factor that we can use to say there is benefit or not from a treatment. Just to mention that all the other ratios are clearly less than 1. The PFS2 are encouraging. We will come to a comment about PFS2 and 1 in this trial, but the point is, as is defined, PFS2 is consistent, but is still immature, only 54% of the data that are needed. The safety of the drug seems really, really good. You see here the adverse event leading to discontinuation for camizestrant in the camizestrant is 1%. In the aromatase inhibitor is 2%. So, I mean, it's very small. It's incredible well tolerated. And also, if you look at the side effect, if you adjust for the duration, you really don't see any potential side effect. But also look at photopsia. Photopsia is known as a peculiar side effect. Only 20% of the patients have photopsia, essentially all of them as a grade 1. And even the only 1% that have a more serious, this disappears after stopping the drug. I already have mentioned the quality of life benefit. We really need to understand why this happened very early. And so my take-home message of SERENA-6. So I start with the limitation because I want to be fair, and I agree with some of the comments made by Angela De Michele when comment in the plenary session, the SERENA-6 results, then were published in New England. So this trial tests two, I would say, hypotheses in one time. So one is using camizestrant, that is a very potent SERD. And the second one is giving camizestrant at molecular progression. So it is intrinsically impossible in the trial, as it is designed, to discriminate if, okay, is more the camizestrant that drive the benefit, is more the targeting early molecular progression, and the wording. Okay, so PFS1, technically speaking, is progression at the first line. Is progression at the first line of treatment, not to the first regimen. But it's true that if you count the line of therapy, not the classical definition, during the PFS1 in the experimental arm, you give 2 drugs. So this is a correct consideration. My opinion, this is not going to affect the overall consideration of the child, but that is absolutely correct. And the optimal timing of ctDNA, we don't know. So my personal take-home message now come from the limitation to my, that is a positive child, demonstrating that if you're adopting this strategy, you can really target and overcome acquired resistance. And I totally believe that mature trial results, so the final PFS, just to remind, this was a positive interim analysis. So the final result will really help us to establish the benefit, despite some intrinsic limitation in the child design. So there's even more, my opinion. If I have the drug available, reimbursed, so I can afford to have the drug, and also the test for ESR1 that is affordable, I will use this strategy. Because, my opinion, we already have a clear indication that is potentially useful. There is a lot of if, but that's my position. Now we look at the algorithm, and we come back to, remember I told you, okay, now we look what is happening in this scenario, post-CDK. So first of all, just to remind that PI3K pathway is driven by PI3K, but there is 10% of the alteration that are PTEN-driven and AKT1 driven. The Capitello 291, as you know, use capivacate, that is an AKT inhibitor. And because it's AKT inhibitor, can also target PTEN alteration and AKT alteration. So these positive results drive the decision of the FDA EMA to approve the drug. These are the most important results. If you consider just the PI3K pathway alterated tumor, because the drug was approved only for patients with the target positive population, and it has been shown that the benefit is similar, AKT, PTEN, and PI3K. You have a proportional reduction of progression of 50%. So in terms of effective treatment, this is an effective treatment. You don't see any clinical factor, no liver metastasis, no previous CDK, no previous chemo that can help us to say, oh, this is working only in this group and this other group. What about the Emerald? I showed you before. The Emerald trial clearly demonstrates the benefit of elacestrant in ESR1 mutated. Just for you to remind this very important table, look below. These are all ESR1 mutated patients. Look at the patient that progressed to CDK in the first 6 months, or between 6 to 12 months. In the elacestrant group, in both groups, the median PFS is 1.9 months. So that's mean more than 50% progress early on. And you essentially don't have any patient that go over 6 months. You have 5.46 and no one in the previous group. So it's not working. It's not working in this group. Instead, capivasertib, if you enroll endocrine resistant primary tumor, the definition of primary resistant with CDK is progression within 12 months. So this was included here. You see the same benefit of endocrine sensitive. So it's very different. Monotherapy with elacestrant not working in primary endocrine resistant. Capivasertib can work in primary endocrine resistant. So this is the benefit of elacestrant in patients with a progression after at least 12 months of CDK, published on Clinical Cancer Research, 8.6 median PFS month. So quite a remarkable benefit if you consider with a standard of care. So for sure, this population, we should offer the option. But still, just to consider, in this population, despite the selection, you have 30% of the patients that progress the first assessment. So what to do in the clinic and how to choose what you have to do between this option. Especially when you have a patient that is both PI3K pathway altered and ESR1 mutation altered. I didn't mention alpelisib just because in Europe is not essentially available after CDK because the EMA approval is with endocrine monotherapy. So I didn't mention, but there is also another reason. The tolerability of alpelisib, in my opinion, is worse than capivasertib. So if I have both available, I will personally choose always capivasertib. So to be transparent, that is the reason why I didn't mention. But with progression below 6 months, you see, I think that probably the best option to consider is still chemo or ADC if available and is possible. PARP inhibitors for sure if the patient is BRCA mutated. Fulvestrant capi for selected patients, like the one that don't have a high burden of disease, you can try because there is demonstration that is effective. So yes, fulvestrant capi for some of these patients without like a large burden of visceral involvement. Between 6 to 12 months, probably capi and fulvestrant is really the first option that I will keep in mind. More than 12 months, I would say almost all the patients should receive or fulvestrant capi or elacestrant. What about the EMBER-3? The EMBER-3 trial, you know, compare imlunestrant standard of care or imlunestrant abemaciclib. Be careful, not all these patients receive a previous CDK4/6 inhibitor. And if you look on the left, you have the curves that are interesting for us. So the ESR1 mutated patient. In the ESR1 mutated patient, this graph tells us that if you add on abemaciclib to imlunestrant, you are more effective. The only caveat here that we should see this curve split by having received previous or not previous CDK, because of course, usually our patients have received a previous CDK. So just to mention and remind all of you that when we take a decision, we are not treating a tumor. We are treating a patient. So our decision should take in account all the elements that are important for a patient. And another thing that is very important for me to remind and share with all of you that the sharing decision-making means that we describe with patient the option. We provide the patient the technical information about the efficacy data, the tolerability, and we help the patient to participate to the decision. That is what is shared decision-making. It's not telling the patient, oh, these are the options, these are the benefits, you decide. No, we decide. So it is a shared decision, not on one side and not on the other side. And I would be very happy to participate to the following discussion. And of course, if you have a question now, I would be happy to answer.
So thank you very much, Professor Bianchini. That was a wonderful, wonderful talk. And I mean, those of you who are experts in the field or not experts in the field can make out immediately that when you hear from an expert who's done all the things hands-on, it's a different ball game. So we have actually some time slotted for question answers, and it is my pleasure and privilege to invite Dr. M.V. Chandrakant to do this question answer session. It's going to be an abbreviated session. Chandrakant, we'd like to finish in 5 or 7 minutes. And everybody knows Chandrakant. He's from Kolkata. For those of you who don't know him, he's the academic head of medical oncology at the Narayana Super Specialty Hospital in Kolkata. And I see at least 4 or 5 questions in the chat box. And if anybody has any other questions, Dr. Chandrakant will take us through the question answer session. So over to you, Chandrakant. Thank you.
Thank you so much, sir, for that introduction. And thanks, Professor, for that wonderful question, wonderful session. Well, I will just point out 1 or 2 questions for you. I've just typed them to keep it simple and clear. So just the design of the trial, if you look into, you had 3,000 odd patients, 548 tested positive, and then the remaining didn't have ESR1 mutation. So what happened to the remaining ones? Are you still following up? And what happened to the remaining 759? Any thoughts, Professor, on this?
So this is a very good question, and probably was not really clear in the description of the first presentation. But you know, when you present the data in a plenary, you have 12 minutes, and it's very hard to go in all this detail. So I will invite you to really look at the supplementary in the New England, because many of the information are there. But really to answer, so the Serena 6 has a design in which you could enter a patient that follow the criteria of enrollment. The criteria was a potential accessible disease. So like complete response couldn't enter in the trial because couldn't be enrolled in the second phase because of the no target to follow.
Right.
And they could enter at any time. So that means that we enroll one patient just 1 month before the screening phase closed. So that means that this patient have just one test.
Right.
And if the patient count negative, it is accounting this 2,708, but she received just one test. And the screening increased a lot in the last period. So we have a lot of patients entering the trial that have received just one test, not several tests. So that is important because this is not easy to present. It's very different from PADA-1. You know, in PADA-1, you can really give the proportion. And one could say, we know that almost 40% of the patients that clinically progress to aromatase inhibitor CDK develop a ESR1 mutation. Why doesn't match the proportion? Because this is not followed. You know, it's like many patients are just look one times. That's why some patients are missing.
Right, sir. I think we are clear about it. Yeah. So measurable disease is required and more tests were required.
Not measurable, available. So like you could enroll patients with bone mets, but is the standard requirement. So at least a lytic lesion that you can evaluate, or like small lymph nodes, but you can measure, you can evaluate. All the patients with complete clinical response couldn't enter in the trial because, you know, if they change, is a clinical progression. If they didn't change, you couldn't enter in the randomized part because the randomized require not miserable, but available, very available or miserable.
Right. So just on the dose of camizestrant, you know, in the Serena 2, 150 was more effective. So why was 75 used in Serena 6? Any thoughts on this?
Yeah. As you know, in Serena 2, there was at the beginning 3 arms. Actually, there was also 300 milligram. 200 milligram, 150 milligram, and 75 milligram. At the end, the higher dose was closed because of the higher toxicity. And the 150 and 75 looks very similar in terms of efficacy. So at the beginning, there was struggling to say, should we use anyway 150, even they seem similar, but there was a slightly higher rate of side effect. And at the early beginning, they was thinking to use 150 because they say, okay, we didn't have any evidence that is better, but we don't want to take risk. But then come some data from the neoadjuvant trial. The neoadjuvant trial confirmed no difference in efficacy between these two doses, but also confirmed a little bit more toxicity with 150. So all the camizestrant program, also in the adjuvant setting, the Cambria 1 and Cambria 2 use 75 milligram because AstraZeneca believe that the efficacy is the same, but the toxicity is less.
Right. I think one last you can take up, sir. So, I mean, are we certain that offering, because there was no crossover in this trial, are we certain that giving at molecular progression improves survival, or should we offer a radiological progression?
So just to approach this question in three pieces. First of all, Elacestrant has been approved by FDA and EMA without any evidence of overall survival benefit. So just for everyone to know, the Elacestrant is not affecting overall survival. The reason why you haven't seen data is because there are no data, because the trial is mature, and you will not see in the future data of overall survival. So the first question is, why you accept Elacestrant without benefiting overall survival, and now you ask you want overall survival benefit for this drug using this set? So you should be fair. You can say, I don't believe in ESR1 targeted drug, but if you believe, you have to be consistent and say overall survival is not an issue. Second point, crossover. ASCENT-04, ASCENT-03, crossover. DB09 with trastuzumab deruxtecan, no crossover. But in DB09, you can question the crossover because you have a drug that demonstrates an improvement in overall survival in DB03. But for camizestrant, why you ask the crossover for a drug that is not approved, is not used? So I know that Angela De Michele point of the question of crossover, but that is a question that that means that every new drug should have a crossover. Why? Why? You have to prove that the drug is effective, then you offer a crossover. And you cannot cross over with a drug that is on the other, I would say, another company. Like, okay, but I want to use a Elacestrant because that is the approval drug. So the point of the crossover, to me, is not a critical point. It remains that without not a crossover, that's a different thing. Without an arm in which you follow the patient and you give camizestrant, so it's not a crossover. It's really a different arm in which you give camizestrant a progression. You cannot answer the question, not of the benefit of camizestrant, but of the targeted molecular progression. And that is why I told you three reasons why I believe molecular progression are good. I can give the drug to all. I have an early benefit in quality of life. I have a demonstration of long-term benefit for some. And I have an immediate benefit that I don't see in the metastatic setting. For all these reasons, to me, I am already prone to think that there is a benefit. And if approved, I will use the drug.
Thank you very much, Professor Bianchini. Thank you very much, Dr. Chandrakant. So as we get more and more molecule approved, as we get advances in science, as we can detect the mutations earlier and easily, the complications increase. And to bring out some of these complications, we have a case-based panel discussion. And the moderator of this panel discussion is Dr. Shyam Agarwal, who's been a very dear friend of mine. He is one of the top medical oncologists of the country, if not the world. And he is presently chairman of medical oncology at the large and very prestigious Sir Gangaram Hospital in Delhi. So I'd like to request Dr. Shyam Agarwal to take over and do the panel discussion. And I request him to introduce his panel. So over to you, Shyam. Shyam, are you there? I can see you on video, but we can't hear you. Shyam, are you there? Dr. Shyam, come in, please. I think your video is frozen, Shyam, but can you unmute yourself, please? We can't hear you. I suggest that if you, what I can make out is that you are in your car and traveling. Maybe you can switch your video off and just use the bandwidth for audio. We can't hear you. Sham, can you hear us? Can you raise your hand and tell us that you hear us?
So can you hear me now?
Little bit we can hear you. May I suggest that you switch your video off and do only the audio so that you can utilize the full bandwidth for the audio.
So can you hear me?
We can just hear you. Go ahead, please.
Okay, so good evening to everyone. And thank you, Hemant, and the organizers for inviting us and bringing us together on this platform. So I think we have the panelists. Dr. Chandrakant is already here. Dr. Sanat, he's from Hyderabad. Dr. Saurav Mishra, he's again from Bhubaneswar. Dr. Srivastava, he's from Kokilaben Hospital, Indore. Dr. Trupti Pai, already spoken. She's from Tata. Dr. Akash Tiwari, he's in Indore. And Dr. Vaibhav from Mumbai. And we have Professor Bianchini, who will continue to be with us. So can we have the next slide? So these are changing times because I think this is the first time that we are doing something based on the molecular alteration, at the time of progression, not at the baseline. So drugs are getting approved. So can we have the first case? Can we have the next slide, please?
There are the slides visible.
So I think there is a slide seen. There is a slide before this also, if they can show it.
Yeah, go ahead, please.
So this is a 48-year-old premenopausal female with left breast lump. And in May 2021, she's diagnosed to be having stage 2 infiltrating duct carcinoma, ERPR positive. And she undergoes lumpectomy followed by adjuvant chemo radiation and 5 years of tamoxifen with ovarian suppression. So in February 23, she develops bone metastasis with small bilateral pulmonary nodules. And the biopsies confirm that it is metastatic disease, ERPR positive, HER2 negative, and she started on palbociclib and letrozole. So almost a year plus and maybe 4 months down the line, she, is doing well. Next slide, please. Next slide.
So just a second, I'll reshare the slides. Yes, sir.
Can we have the next slide, please? Okay, so now in December 2024, the disease is progressed in bone and lungs. Next slide. So the question is that this patient, has progressed on palbociclib and an AI, and the gap is more than a year. So, and the biomarker testing or re-challenge with CDK4/6 ET. So what is the best approach? Can we have the next slide? So we can have Dr. Saurav, what is your take on this particular patient when a patient is progressing after a gap of 1.5 years on, a Palbo or a CDK4 and AI? So should it be, yeah.
So, sir, basically, this patient has done very well on the palbociclib and the endocrine backbone, that is aromatase inhibitor. So, at the time of progression, we have options of either re-challenging with another CDK4/6 inhibitor, or we can go for novel therapy. But for that, we need to go for biomarker testing. And for that, mostly we would be looking for the PIK3CA mutation, ESR1 mutations, and germline BRCA. Probably that is what we would be going in.
So, does Dr. Weber, what do you think? I mean, what will you be doing in your day-to-day practice with this patient who's progressing in bones and lung on, a CDK4 and AI?
Yeah, definitely, sir. It's kind of a, we cannot call it a oligo progression because it has progressed at multiple sites. So here we will do a NGS testing, liquid biopsy preferably to look for the biomarkers and then proceed accordingly. In the interim, if patient is just too much symptomatic, then might be we might go in for fulvestrant as well at this point of time. But then I think we get these reports, turnaround time is around 10 to 12 days for liquid biopsy mostly. So I will wait for the biomarkers.
So you will do the biomarkers on the
Yes, sir.
tissue or on the liquid. So would you do a
Liquid.
biopsy? Okay.
No, sir, liquid, sir, because it's a multiple site progression. So liquid biopsy, as Dr. Trupti also highlighted in her talk, that ESR1 actually, liquid biopsy is more sensitive and better test for ESR1, and that is true in the metastatic setting. So routinely we go in for liquid biopsies, sir.
Okay. So, Dr. Srivastav, so what will be your approach? And then we'll come to Professor Bianchini to have his opinion.
Yeah, good evening, sir. As Dr. Saurav and Dr. Weber rightly said that sir, this patient had responded nicely for the first line CDK4/6 inhibitor, and he has completed the almost the PFS time more than 12 months. So now there is a progression. As we know that the re-challenge with the another CDK4/6 inhibitor has not shown a much response. So I would definitely go for the biomarker testing by liquid biopsy to go for PIK3CA, ESR1, AKT, PTEN. So just to guide myself for the further treatment.
Okay. So, Professor Bianchini, I mean, this is a common case scenario in our day-to-day practice. And we do have access to NGS, and the liquid biopsy is available. So would it be prudent to, as I think the first speaker said, that he'll go for fulvestrant and maybe continue with Palbo or maybe change the CDK4, or would you go for NGS right away?
So for sure, I will go for NGS. And if negative for ESR1 mutation and PI3K pathway alteration and is not BRCA mutated, I will consider a change in the drug. In this case, my preference go to abemaciclib and fulvestrant, and the reason is because MANTAIN trial is a phase 2 trial, investigator initiative, with a smaller sample size. The post-monarch instead is a phase 3 trial with a much more stronger, power of the study, and also is supported by the results of the EMBER-3. I know that the EMBER-3 is different, but these also confirm that the use of abemaciclib after CDK is effective. So I would really prefer using abemaciclib if is wild type for everything.
Right. So the other question was, if the tissue is accessible, would you repeat a biopsy at this 1.5 to 2 years interval rather than doing liquid biopsy?
So that's a very, very good point. So at this stage, the patient have a bone that is not good for any NGS. So you cannot use bone for NGS except you have a tissue and a small lung lesion. So not easy to biopsy. But imagine that is a liver. Should I biopsy the patient? And the answer is at this stage, no, because what we know is that we can use liquid biopsy and we can use archival tissue. So essentially, PI3K, PTEN, and AKT alteration tend to be quite stable during the time. It's very infrequent that is acquired a PI3K pathway alteration. So what we usually do is we do a ctDNA and we do a primary tissue. And why the reason? Because what I explained very well in the previous presentation, for many tests available, also in the market available for PI3K, the frequency of negative result because of the technique, not because of the biology for PI3K, is close to 45%. So you need to have a tissue assessment to be sure that the patient is not positive. The second, 10 alteration cannot be captured by ctDNA. So if it is affordable, I will ask for a ctDNA testing and a tissue, NGS on the archival tissue.
So those are very, very important points which Professor Bianchini has made, that the primary tissue is good for looking at PIK3C and other genes also, because perhaps on the ctDNA, we may not be able to pick them up. So, I mean, ESR1, of course, is picked up better on the ctDNA, and that's why we rely for ESR1 on ctDNA. So I'm just going to show you a few slides before we ask the next question. So Dr. Bianchini was mentioning about the maintain. So, you know, in our country, we don't have, we only have drugs like alpelisib, which is not very, sort of conducive agent because of its toxicity profile. So if somebody is good, and we also don't have the second generation or the third generation SERDs. So I think switching a patient on maintain may not be a bad idea in the absence of the information available. Next slide, please. And that's what some people and a lot of people do. So this is Abima, I think he was referring to in combination with fulvestrant, so which is another option. Next slide. So here again, the PFS is better with the fulvestrant abemaciclib. Next slide, please. So I think we've addressed some of these questions. Next slide. I think we are looking at PIK3C, we are looking at AKT, and ESR1 and BRCA1 and 2, PALB2. And of course, you also get information on ERB2 when you do the NGS. So P10 again is another gene which we are kind of looking at in the NGS. So a few of these questions have been addressed. Dr. Sanath, you want to add anything into this discussion in terms of the availability of the liquid biopsy and the gene preference?
No, sir, nothing. I would like to see the symptoms of the patient. So if the patient is so symptomatic, then mostly I would like to prefer chemotherapy, sir.
Yeah, here is a patient who is fairly well preserved in spite of...
Then I would like to check for the biomarkers and as possible hormone therapies or target therapies. I would like to avoid chemotherapy, sir, because she is the best patient to start on biomarker treatment, because she has very good PFS on single agent hormone therapy, then on CDK4/6 and AA. So I would like to check for biomarkers, sir.
So, Professor, I think a pertinent point has been raised based on the symptomatology of the patient. So, if the patient is having mild cough and some hemoptysis, not patient is walking up and about with ECOG1 and you find PIK3C. So would you be offering them targeted therapy, or would you switch to chemo?
I would say it's very hard because depends on the symptoms and depends how I think that a short attempt for capivasertib will allow me to shift to chemo without the risk of losing the patient. So that is, I would say, is something that you cannot standardize. You are a good clinician, you have this feeling, that there is space or not. If no space, I will go for chemo. If you feel that, yes, there is like symptom, like pain, okay, but you're not risky, what I usually do is I do a targeted agent, but I do the reevaluation very short on time, like in the clinical trial. So 6 weeks and I see if there is a trend. If the clinical improve, and like I have a biomarker like CA 15-3 that decrease, okay, I go ahead. Imagine the opposite, that you are a worsening of the symptom, even after first cycle, and you have an increase of the biomarker, I shift with chemo. So the point is, I prefer to attend to use the target agent every time I can, but I'm very, very close to monitoring the patient and be ready to shift to chemo.
Right. So I think, Dr. Chandrakant, you agree with this? I mean, if patient is mildly symptomatic and you would still like to give a chance to targeted therapy rather than jumping onto chemo?
Right, sir. I think Professor showed in the last slide the duration on first line endocrine plus CDK4. If it is up to 6, then I am concerned. I will give chemo or an ADC. 6 to 12 months, I think that's an area where you have a discretion. More than 12 months, a target is the way to go. I think duration on first line therapy will be another decision making point for me.
Right. So I think these targeted therapies are really changing the way we think about our patients. I mean, it's something like a visceral crisis, which is pushing us into chemotherapy. If otherwise patient is well preserved and mildly symptomatic, one can still perhaps stick on to the targeted drugs and watch them closely and be sort of ready to change. Next slide, please. So, NGS in this patient was done and identifies activating mutations in AKT1, E17K with additional alterations in PIK3CA, but no evidence of ESR1 mutations. So this patient on NGS is showing. So, Professor, what is your take? I mean, and as we said, patient is well preserved.
Yeah, I will go for sure for because here the duration was almost 20 months because she started in February 2023, she progressed in December 2024, very long duration, not a huge amount of disease. I don't think this could be considered a visceral crisis, so I will give a capivasertib for sure. Of course, if you don't have capivasertib, I will give a try to alpelisib. But all these patients, I follow very strictly with a second evaluation, the first time not longer than 8 weeks, between 6 to 8. Then, if everything is good, we usually start every 12 weeks, just because of the cost of TCA assessment and so on.
Okay. And Dr. Trupti, are you there, please, ma'am?
Yes, hi.
Yeah. So, I mean, you showed slides on various types of ESR1 mutations and PIK3C. So, what is the relevance in practice, for those mutations?
Sorry, ESR1 you said?
Yeah, ESR1 and PIK3CA.
Uh-huh.
So if
Clinical
you pick,
relevance.
yeah. So if you pick up a particular mutation, are all mutations relevant, or they should be in a particular domain, or what is your?
Yeah. Yes. So it is usually in the particular domain. So for ESR1, it is mostly in the ligand binding domain and also most commonly concentrated along the codons, specific codons, of which if you see in ESR1, like most common, like most aggressive is considered to be a 537. So why 537S is considered most aggressive of and most resistant to air. So there are most common hotspot in a particular region, but then there is evolving literature about one particular alteration being more significant or maybe with more clinical prognostic value.
So, Professor Bianchini, any thoughts on the type of alteration and the response or the selection of drugs?
Actually, this is a very, very, very good question. And in some of the trial, the patient to enter doesn't need just to have like a PI3K mutation. So they really mention the type of mutation that the patient should have. And exactly for, as we do for BRCA alteration, or that we say is a pathogenic alteration or is a passenger. Also for these genes, sometimes there are passenger alterations. So the involvement of the specialist, especially when the mutation are outside the hotspot, is critical, because you can have a mutation but is in a place where biologically you know that is not going to affect the function. And it's important to have in the team a pathology, a molecular biology, or a molecular tumor board that really help in this interpretation. We have in our hospital, but if you don't have, just take a young doctor or in the residency and say, oh, you have to study all these things, because it's very important to keep the peace. There are databases that you can look at. You can look at the TCGA, where you find some alteration that are, you see immediately, you see CBO portal, you see the alteration that are really very far, never mentioned in thousands of patients. I would really not consider this as a sensitive alteration. But again, no, not all the alterations are the same. The hotspot are fine. Outside the hotspot, the non-alteration is important to interpret them.
Great. So I think those are very important points. So having a molecular biologist on board for helping in decision making is always helpful and should be on. The next slide, please. So there are a lot of slides. Next slide. Next, please. So I think this is the point which was made. Go to the previous slide, please. Yeah. So, the PIK3C, you get the primary tumor sample and the matched recurrent sample. Dr. Bianchini, you have a comment on this slide? Does the incidence vary for AKT1 and P10 in the archival tissue and the subsequent biopsy tissue?
Yeah, you see that the number are very, very close. So is the shift that you have are potentially also in the space of the sensitivity of the method. Sometimes when you have a metastatic biopsy, if the cellularity is low, but can happen also in primary tumor, sometimes if you don't use very good NGS, you can have discrepancy. But this is really tell us that overall, these alterations tend to be truncal. So they are not, I would say, acryl, because they are not subclonal. So and 10 is particularly complex, but these really support what I was telling before, that if you have a biopsy, of course I will use a biopsy. But if I don't have the biopsy, I don't feel the need to push to biopsy a patient. I use the archival tissue.
Thank you. So let me ask one question. We have to, I believe, finish in a few minutes. Dr. Saurav had asked that if on the subsequent follow-up you find ESR1 and PIK3C both altered, mutated. So what is the treatment at that point in time after having given a patient CDK4/6 and an AI? Professor Bianchini.
So as I was mentioning in my slide, so the time of duration of CDK is probably the major driver. So every progression within 12 months, PI3K targeted drug, and I would not consider elatustrat even without a PI3K targeted drug. So we don't have any evidence that elatustrat is working in this population. For patients who stay more than 12 months, I usually use the clinic. So PI3K targeted agent has a higher response rate. So all the slightly symptomatic patient and the one in which response is relevant, not so visceral, so is more responsive relevant, I prefer to offer a PI3K targeted agent like capivacin. For all the patients in which response is not an issue, I would prefer to start with elachestan because of a very good tolerability. So it's a monotherapy treatment. The patient tolerates it very well, and I prefer to start with a third and keeping the PI3K targeted agent for a later line.
Thank you. So my final thoughts would be, yeah.
Yeah, so sometimes do the VAF will make a change in your decision. For example, if a same case has ESR1 lower VAF as against other alteration which has a more VAF, will that affect your treatment decision?
That is a very good question, not easy to answer, because in the Emerald trial, there is a poster presentation very recently in which they look at the VAF, and they didn't find any different efficacy according to low and high VAF. So the efficacy doesn't seem to be matched to the VAF. But this analysis didn't do an analysis like of a comparison of VAF within the same patient. Like, for instance, you have a PI3K alteration with 20% VAF and the ESR1 mutation with 1%. That is different thing to compare with a patient that has only the ESR1 mutation to 1%, because this really suggests that ESR1 that you detect is subclonal. When you have 1%, you cannot speculate about clonality because you don't know the shedding relevance for that specific tumor. So in the second case, I would say VAF doesn't matter at all. In the first case, maybe, but I don't have evidence. I will look at the VAF.
Okay, thank you.
Thank you, Professor. So my final question is that now if you have everything available and you're putting a patient on CDK4/6 and AI, so are you in clinic looking at the ESR1 mutations at 2-3 intervals, and when do you start and do you act on this?
The short answer is no, because you say everything is available. So I have the money for the test. I have the drug available. Yes, I will do. Probably not for all the patients. I still need to understand which is the best timing, and probably just for reason of cost, I will retest the patient every 4 months instead of 3. Yes, I will implement a strategy.
So, and if the ESR1 is found to be mutated, you will switch to the. I mean, you'll add the third, right?
Yeah, absolutely. So, because you say that everything is available, that means that if the Serenity will bring to the approval of the drug, I will use the strategy. I will use it, and I just tell you that. Probably because of the cost of the testing, I will retest every 4 months. I know that is not the best strategy, but it seems like an equilibrium between the cost and the efficacy of the strategy. So I will probably try to apply a strategy like this, because I'm not really sure about how we can sustain the testing. But if there is no issue, I will retest every 3 months.
So, does it open up a window of opportunity for other cancers? For example, EGFR mutated with L858R, and 4 months down the line, you find on a ddPCR 790M, and so is it worth switching to the next generation TKI? So isn't it opening a window for so many other cancers where you can find, and as we know, the mutations do precede by 7 to 10 months before they show up on the PET scan or the CT scan?
The answer is absolutely yes. So I strongly believe that if, with all the limitation of the design, not the crossover, but the control arm to really prove, if Serena-6 is accepted, because at the end we believe demonstrate the benefit of targeted molecular progression this could be potentially applied to many solid tumors, in which you have an alteration like the one that you mentioned in lung that is really linked to an acquired molecular alteration. And so absolutely, yes, I believe that this could
Right.
be a
Right.
paradigm shift trial.
Yeah, Chandrakant, you had some, questions on the study. So would you design a study on other malignancies to change the course based on the molecular alterations? Would you design a study differently?
If imagine like a trial with osimertinib. Osimertinib has already proven to be effective. So in this case, in this specific case, I would design a trial in which I have a strategy in which I do not implement the trial testing strategy with an arm in which I implement the trial testing strategy, so targeting molecular alteration. So because in this case, again, will be different because you have a drug that is approved. We know that is working. And the question is, do I really need to do a change at molecular progression? So in
So
that case,
Shyam,
we design a trial in a different way.
So Professor Bianchini, we are 10 minutes over time, and Mr. Moderator, sir, with your permission.
I think we
if
are
you could-
almost at the end. Chandrakant, your thoughts? Would you design another trial and that will be the end of the discussion? Chandrakant, your
So
thoughts?
I think, yes, I think sir answered already, you should have a drug to act upon. If you do not have a drug, I won't design. So just one last question, instead of doing a Garden 360, I can do a focused PCR of that particular ESR1, just like we did in PADA, the PADA 1 trial. So I just wanted the thoughts from Professor, because it's not possible for us to do Garden 360 in every patient.
Yeah, it is, the best way eventually to implement and the PADA one or additional strategy, I believe need to be established. So hopefully after Serena 6, we will see some investigator initiative trial with the aim to make this strategy applicable also in context of economical constrained resource. So I believe that this is a very nice trial. In some place you can probably apply the trial as it is, but we need to really understand a lot of things, even how to improve the use of dynamic ctDNA to better follow our patient.
Right. So thank you very much, everyone, for this interactive discussion. And new areas seem to be opening up with these studies, and new drugs are coming in. So I think over to you, Hemant. Thank you all. Thank you very much.
So thank you, Shyam. Thank you, Professor Bianchini. Thank you, Dr. Chandrakant. Thank you, all the panelists, for all your valuable inputs. So, ladies and gentlemen, if I were to take a couple of minutes to wind up, as Dr. Shyam has pointed out, the field of hormone receptor positive breast cancer is seeing a phenomenal expansion in alternatives which we have. We have lots of new drugs now. We have identified mechanisms of resistance. We have ways to detect those resistance, and our molecular techniques and tests, including liquid biopsy and the next generation sequencing techniques, they are going to be the game changers. We have so many permutations and combinations now that it is probably mandatory to have a molecular tumor board now, where all the clinical inputs and the molecular inputs can be, discussed under one roof, and a way forward for the patient can be sought. A few of the important things which came out during the discussion was the importance of liquid biopsy, the importance of doing molecular tests at progression, and the importance of the time when the recurrence or the progression happens, what drugs the patient has taken in the past, what options are available, which part of the world are you working, do you have a choice of multiple SERDs, or do you have only alpelisib as is happening in our country? But we do expect maybe this year or in the next year, quite a few of the SERDs to be oral SERDs to be available to us, and then the options of treatment for our patients of hormone receptor positive breast cancers will increase and expand. Then, of course, we have the option of chemotherapy for these patients, which we try to push as far back as possible and avoid the toxicities of the chemotherapy. And I just liked Professor Bianchini's slide that the patient has to be a key element in the decision making. When you have multiple options of treatment of any disease, then you have to have the patient and the clinical team decide together. So with that, one more time, many thanks to all the participants. Many thanks to the ISMPO for supporting this CMA, and I'm sure that the attendees who attended this meeting, they go back with an increased repository of knowledge, which can be applied to the patients from Monday onwards. So thank you very much to the sponsors, and thank you very much to our participants, particularly Professor Bianchini, Dr. Shyam Agarwal, Dr. Chandrakant, Dr. Trupti, and all the learned panelists. So you have a wonderful weekend, and with that, we'd like to sign off. Would the AZ people want to come in? We are done from our side. Anybody want to come in?
I want to thank you all for your hospitality. It was really a pleasure. And I really enjoyed the discussion. I think that all around the world, physicians think in the same way, because at the end, we are treating the patient with the same disease.
That's right. We look forward to welcoming you to India in the physical way sometimes in the future, Professor Bianchini.
It will be a great pleasure.
Thank you, sir.
Thank you, everybody. Goodbye. Enjoy your Sunday.
Thank you.